I take my little text and I guess once in a while. Not a lot. Weekend warrior. And yes, I say because of it. Oh, and then I'm so mad. I screwed up.
Good morning, everyone.
Good morning.
Welcome to Friday No and Go. Glad you could all make it this morning. Holly Brenner is taking a little time off, but she's asking if I could fill in as host. Good news, she gave me a script, so I'll go through that this morning. But let's begin, as we always do, with a reflection. A group of American school children were asked to list what they thought were the present 7 wonders of the world. Though there were some disagreements, the following received the most votes: Egypt's Great Pyramids, Taj Mahal, Grand Canyon, Panama Canal, Empire State Building, St. Peter's Basilica, and the Great Wall of China. While gathering the votes, the teacher noted that one student had not finished her paper. She asked the girl if she was having trouble with her list, and the girl replied, "Yes, a little. I couldn't quite make up my mind because there are just so many." The teacher said, "Well, tell us what you have, and maybe we can help." The girl hesitated and then read, "I think the 7 wonders of the world are to see, to hear, to touch, to taste, to feel, to laugh, to love." The room was so quiet that you could hear a pin drop. The things we overlook as simple and ordinary that we take for granted are truly wondrous. A gentle reminder that the most precious things in life cannot be built by hand or bought by men. Got a couple of quick announcements or things I'd like to bring to your attention before we introduce Dr. Royce. Is the Treffert Center, and Drs. Treffert and Dahl will be here on September 9th, the next No and Go, to update you on what's going on with the Treffert Center and their work. It should be an excellent presentation, so mark that on your calendars. There is a card for feedback on the table in front of you. Our marketing department values this feedback and how they set up the future programs, so please make sure to give them some feedback on the yellow card today. And then finally, the green card, which Katie will collect at the end. Fill it out if you'd like to be in the running for a door prize, a very nice bag with some exercise band and hydration equipment over there. So please fill out the card for that. With that, I'd like to introduce Dr. Bryan Royce. Dr. Royce is an orthopedic surgeon working with Agnesian HealthCare in the Fond du Lac Regional Clinic. His office is over in Health Plaza 8. He specializes in both child and adult orthopedics. We take you from initial diagnosis, conservative management, surgical care, follow-up, rehabilitation. Dr. Royce is very skilled and really does it all in the orthopedics world. He is a graduate of Rush Medical College in Chicago and did his residency in the University of Wisconsin in Madison. He and his wife live here in Fond du Lac. Dr. Royce enjoys traveling, hunting, outdoor activities, watching football, and reading. So please enjoy the presentation and join me in welcoming Dr. Bryan Royce.
Excellent. Thank you. Is this loud enough? All right. I'm surprised how many people are here. I did not think this kind of turnout showed up every Friday morning, but it's excellent. So we're going to talk today about some tips for the weekend warrior. This is something I see in my clinic every single day that I have a clinic open. Whether I have 3 people scheduled or 30, there's always someone who comes in who fits this description of a weekend warrior. Like Mike said, we're out at Health Plaza A. My new nurse practitioner, Ashley, is here somewhere. She works with me. We'll be seeing patients, like Mike said, little kids who fall off the monkey bars to 90-year-olds who fall off the front steps. So if you have any problems, you know where to find us. So we'll get into the talk. So this is the strict definition of weekend warriors. If you read any research papers, this is what they'll be talking about when they say a weekend warrior. Somebody who engages in irregular patterns of physical activity more than 2.5 hours each week, and they consider it moderate to vigorous physical activity. It's a little bit subjective when you read that description as to, do I fit into that, do I not fit into that? It's a little bit of a gray area. My definition for these people, which I'm probably one of actually, is someone who does physically demanding activity on rare weekdays or usually on weekends, even though they haven't really been training the rest of the week or the rest of the year. So you wake up in the morning and your wife wants to take you on a 3-hour hike because she heard there's this great new park that you guys are going to walk around, but you haven't walked more than 20 feet in the last 3 or 4 months. That qualifies. You have friends that come up from out of town and they want to go out on the lake and go kayaking, and you don't own a kayak, so you have to borrow one. This probably qualifies. Weekend softball tournaments, volleyball tournaments, bar league bonanzas where you don't just play one game, but you play multiple over 2 or 3 days. That qualifies. Tennis tournaments at the club, golf tournaments where you're going to golf more than your usual 9 or 18 holes. Those are all things that qualify in the sporting world, but I think there's things that qualify even if you're not what you consider to be an athlete. So maybe there's a big windstorm, you have a lot of sticks in the yard, and you end up spending 4 or 5 hours picking up sticks, picking up leaves, push mowing the lawn, doing all those sorts of things, and you get done with that work and you're like, wow, I haven't worked that hard in a really long time. That kind of qualifies. People who decide they're going to spring clean their house, do everything they possibly could, wash the windows, get in every corner of the room, down on their hands and knees, stretching up on a ladder or a step stool. Those people will have the same kind of injuries as people who decide they're going to go out and play tennis for 2 hours. In the past, weekend warriors kind of had a little bit of a negative connotation. You heard somebody was a weekend warrior, like, oh, this guy, I know him. Usually it was men in their 30s who couldn't quite give it up. They want to play, after work in the intramurals. They want to play in the bar leagues. They coach their kids' softball team, their son's baseball team, the neighbor kids' soccer team. They do a little bit of everything. They're out there running around. They think they're still part of the team, but they don't, during the week, really take care of their body the way they need to finish those activities. They also miss the camaraderie in the past. They wanted to be part of a team still. They left the frat or they left the military and they missed that, so they get together for another set of competitive games. Things have changed here probably the last 20 to 30 years. Jobs have become more sedentary, so more people are looking for ways to get their energy out on the weekends. They're not chopping wood, shoveling coal, breaking rocks all day. They're sitting at a computer, and so they feel like they need to get out and do something when they have free time, and that's usually just on the weekends. Title IX, that occurred in 1974, that allowed for women to have all the rights in athletics as men. No person based on sex would be held out of sports. And so since that's happened, it's opened a whole new class of patients for what we consider a weekend warrior, because so many more women began participating in sports in school, college, and stayed active, and are now still staying active. And also in the last 30, 40 years, we've really learned the value of exercise and staying healthy and living a healthy lifestyle. So today, weekend warriors can be either men or women. People probably start somewhere in their late 20s, early 30s doing this type of activity, this weekend exercise, but they can go up to any age. You'll see this gentleman here running a marathon somewhere. You see people of all sizes, all ages, competing in all different activities. So this kind of applies really to everyone. There's still a lot of team sports, racket sports that are still available to people of all ages. People are getting into distance running more and more. And one of the big things I'm seeing recently is this obstacle course running. So you hear people talking about, I did a Tough Mudder, I did this thing, that thing. They're usually smiling at the end, covered in mud, small electrical shocks on them somewhere. And they're thrilled about it. I don't get it, but they're thrilled about it. And then I usually see them like maybe 2 days later when there's still just a little bit of mud underneath their fingernails and their knees swollen, and they can't figure out why. But that's a new big thing, and it's a boon for orthopedic surgeons, but see, they seem to be having fun. So, and people are just, they have competitive urge. I mean, now is the prime example. Watching the Olympics every night, I think, boy, I could probably do this still. I think I could. You know, I'm like counting off square tiles in my bathroom, like how wide is a balance beam? When I pull off a cartwheel, I haven't tried yet, so I'm not going to either. And people are trying to stay fit. I think the importance of fitness has really come to the forefront in everybody's mind as we get older. So we kind of described what the weekend warrior is. I guess the bigger question is, why do they continue to get hurt, or why is it that an orthopedic surgeon sees so many of them? Well, the biggest issue is these people have a very high competitive drive. Once they realize, oh yeah, I'm signed up for this, I'm going to do it, they want to finish it, and they want to finish it at a high level. Unfortunately, they don't always train with that same intensity that they approach the competition. So their preparation is fairly poor. And mental preparation is one part of competing, but as you get older, the bigger part of competing is your physical preparation. People often have poorer diets as they get older. Everybody's diet has switched to a more processed foods, high carb diet. This actually has effects on your tissues, whether you feel it or not. Even if you're very thin or in what you consider good shape, just over time, just this perseverance of high blood glucose and having these high carb diets will cause your tissues to actually become sugary, and that makes them weaker. And that's a big for us. That's a big thing to point to for patients, that they can try to change, but it doesn't really stop it. It just keeps going. So you have to look for other ways to treat these patients. We'll talk about those as we go on, because you can't just tell somebody, well, just stop getting older. It doesn't happen. Another issue is people start to decline from a respiratory status. No matter how healthy you are, if you're Lance Armstrong, Michael Phelps, as you get older, once you reach about 35, your respiratory status and the amount of oxygen that your body can use starts to decline every year, regardless of how hard you train or what you do. It's just father time. Our nervous system, same thing happens, slow decline. You start to lose your balance a little bit. I would say most of us here probably aren't quite as good with a cartwheel as we were when we were 12. And that's just a combination of your blood flow to your brain, which goes down, the connectivity and the communication between your brain, your nerves, and your muscles. All these things decrease your balance, decrease your reaction time. So it's harder to make adjustments when you're playing sports or when you're training or when you're running. You see a pothole in the road, you might not be able to just nimbly leap out of the way like you used to. And you step in that pothole, then you come see me. Muscle mass deteriorates after age 40, 1% per year. The less active you are, the faster that muscle mass deteriorates. Bone mass loss, everybody knows about the risks of bone mass loss. So osteopenia, osteoporosis, it's a big problem here in this state and all the northern states, because we just don't get a lot of sunlight, which produces vitamin D. And so if you don't have a lot of vitamin D, especially for women, you really start to lose a lot of bone mass quickly, and that leads to fractures and other injuries. Another issue is unwanted weight gain. As we're losing this muscle mass, it's slowly being replaced by fat, which doesn't work quite as well as muscle, and carrying around extra fat does make it harder to compete or to do the activities you want to do. As we get older, there's just an increase in systemic and local inflammatory reactions within the body. We don't necessarily know why this is, why older people, that doesn't even mean elderly people, it just means people who are 30, 40, 50, have a higher inflammatory response to injuries that they sustain. Our tendons, they begin to age, just like I spoke about the glycosylation of tissues or the sugary tissues. Same thing kind of happens in the tendons. Slowly over time, whether you want it to or not, or regardless of what you do to prevent it, they become a little bit hypovascular. They lose their blood supply. The reason the body can regenerate, heal wounds, is because it has a blood supply that brings fresh nutrients, takes away old waste. But when the blood supply stops, then the body can't heal itself quite as well. The repetitive micro trauma, climbing up and down the stairs, running up and down a hill, getting up and down off the floor, playing with your grandkids or your kids or the neighbor kids. This all causes little micro trauma within your tendons, and normally your body will just take that trauma away, will remove any little torn portions of the tendon, and then repair it. As you get older, you can't do that quite as well, so slowly these things add up and build up and can lead to problems. Most commonly we see this in a couple places: the foot and ankle, the rotator cuff, and even the elbow. So we'll go through a couple common injuries. These will probably touch a little bit on things that you've had, your spouse has had, or the neighbor has had, and I'm pretty sure everybody knows somebody's had at least one of these issues. This is more common in kind of the aggressive athlete. This isn't the person who's just out playing a little badminton on the weekend. This is the guy or girl who decides, I was pretty good at softball when I was in high school, so I'd probably be really good when I'm 42. So then, they start to decide, well, we're down 2 runs and we're going to start sprinting everything out because we're not just having fun, we're here to win. Well, that's usually when you see the person hit the ball, take off to first base, get about halfway down, and then immediately grab the back of their leg, take 2 hops, and then crumble to the side, and then they realize, oh, that's why I stopped playing softball. Yeah. So this is a strain or a pulled hamstring. What it is it's actually tearing of the muscle on the back of the leg. With quick acceleration, you can actually pull that muscle so hard that it actually pulls itself apart or pulls itself off the bone. This is kind of the telltale sign it's the back of somebody's leg, and that takes a couple weeks to go away. Things like muscle imbalance, poor flexibility, failure to warm up, cool down, poor stretching, fatigue, it all leads to these kind of injuries, these muscle injuries. The muscles aren't prepared to take on the load that you're going to put across them. They have 2 options: either they won't go or they'll go and rip. So we kind of talked about this: sudden sharp pain, swelling, bruising. Treatment options. Luckily for most people that suffer a hamstring strain, surgery is not really much of an option. If you're an elite athlete who's in the Olympics, you're going to be a sprinter, you play football, and it's actually torn the muscle off the bone, yeah, then there's a surgery we do to repair the tendon back to the bone. It's not a fun surgery. People are rarely happy. They have a hard time sitting. You don't want that, trust me. The best option for this is just to try to get the inflammation down. We'll talk about this a little bit more in detail, but this is the Royce theory of resting, icing, applying compression, and elevating. All things that will help decrease inflammation, decrease swelling, and decrease pain. Once you've got the pain down, inflammation's down, the physical therapy is very important for hamstring strains to get you moving again and try to avoid scarring in the muscle. So another issue that's pretty common, you hear about it frequently, especially in runners, it's called IT band syndrome. The IT band syndrome is actually located closer down to the lateral side of the knee. This is caused by friction between the tough band of tissue that runs from your hip all the way down to your knee. And that band of tissue runs vertically from top to bottom, but then it crosses the knee, which moves horizontally. It bends front to back. And so between the bending front to back and the running of the muscle up and down, there's a cross between the muscle and the bone. Those rub against each other, and that friction causes inflammation and can cause pain. Very common in runners and cyclists. People who have poor shoe wear, whose shoes don't support the way their foot falls on the ground, it will cause their leg to move in an abnormal way, cause more friction, more pain. Most of the time when I see people in clinic who have this problem, I can spot it as soon as they walk in, and they can say like 2 words like, "it hurts," and they start to point, you're like, oh, I already know what it is. But if you listen to them longer and have them tell you the story of how they got to your office, they almost always say, yeah, I was doing really great. I don't know what happened. I didn't change anything. I was doing so well. In fact, I even started running hills, and they felt great. It's like, uh-oh. And I say, oh, and then my sister joined me, and now, rather than doing it like once a week, now we're doing hills twice a week. We're feeling so good. We're getting so much stronger. That increase in intensity level going from running on flat ground to running up hills or adding sprints to your jogging, that's usually what causes this. It's just a change in the pattern of wear in your knee, the change in the friction, and it irritates the tendon. Again, rest is always important for this. Hard to do when people are trying to train and feeling good, and they feel like they're getting back into being an athlete again. It's hard to get them to rest. They feel like they're going to lose everything they've gained. It's important for most of these injuries. NSAIDs, we'll talk a little bit more about these later, but they're always an option for people to consider using NSAIDs for anti-inflammatory effect. Ice, you really can't go wrong with ice as long as you don't burn yourself, you get a frostbite on your skin. If you got something that hurts, try ice. If ice doesn't work, try heat. You're not going to cure it, but you're not going to hurt it. Physical therapy, stretching is very important for IT band syndrome. We have wonderful physical therapists here at the hospital, out there at the Sport and Spine. They do a fantastic job. And so if you get in this situation, you come see me or you see your primary care doctor that diagnosed you with this IT band syndrome, you can expect you can probably get a prescription to go see the physical therapist. That's a really important tenet of therapy for this. Occasionally we even do steroid injections for these, but unlike a lot of steroid injections, this is a little bit more of a shot in the dark. We don't know the exact spot where the friction's occurring, so we can put the steroid injection pretty close to it, but it doesn't always work 100%. So you just know that going forward. Trochanteric bursitis is very similar to IT band syndrome, just a little bit further up the leg. It's that same IT band, but it's where it rubs across the lateral aspect of the hip. This is very, very, very common, not just for athletes. This is common for a lot of elderly people. I see that oftentimes in my clinic. People who are still active. It's oftentimes in people who are older, but they are still out walking around, doing their own shopping, doing that sort of thing. And they'll always come in saying they have hip pain, and people will be very concerned that they have hip arthritis. And they think they're coming to see me to have their hip replaced. But when they walk in, the first thing they'll say is, it hurts when I get up and I first start moving. It hurts right here on my hip, on the outside, and I can't sleep on that side anymore, so I haven't slept well in 2 months. That's good news when I hear somebody say that, because that means that you don't need a hip replacement. People who need a hip replacement will say that they have groin pain. And they'll say, no, it's not my hip, it's my groin. Well, that truly is your hip joint, is in the groin. So if someone comes in and sees you, or you walk somebody at church and they're limping and they got a cane and they say, oh, it's this pain right here in the front of my groin, yeah, they probably need to see a doctor and consider hip replacement if it's bad enough. People who have it on the outer side of the hip generally don't need a hip replacement. They just need some therapy and possibly steroid injections. This is people who run on sloped surfaces. So if you run on a track that has a little bit of a slope to it, you run hills again, or even people who run on the sides of roads. You know, roads are crowned, so the water will run off. And anybody who's trained for a marathon or a half marathon will tell you that if they train on a road by their house and they go to the marathon and they have to run on the other side of the road, it is a major issue for them, because you don't realize it, but even if it's just up an inch or two compared to the other side, if you're used to running leaning to your left a little bit, and now you got to lean to the right, it's a big difference for your body over 26.2 miles. So people that change their slopes that they run on often run into this problem. NSAIDs, again, a good option for treating this. Stretching and physical therapy, you'll hear people talk about foam rolling. They use these big foam bars, and they have you lay on them and they roll on it, or they use rolling pins and actually rub up and down your IT band to really try to stretch that IT band out. If the IT band is stretched out, it doesn't compress against the bone on the side of the hip so hard, it doesn't have as much friction, and it's less painful. Occasionally, steroid injections work really well for this. There's not a great surgery for this, so do everything you can to avoid it. And if you get it, try to get on top of it quickly, because I've never had to do the surgery, and people who do the surgery rarely are happy with the results. Knee sprains, moving a little bit further down the leg here. Usually you know exactly when this happened. You can put your finger on the exact time. You were running, you twisted, your knee buckled, you go down, or somebody else fell down and rolled into your knee and your knee twists in. You're walking down a hill in the backyard and it twists. It's usually a stretching of the ligaments in and around the knee. The four famous ligaments within the knee include the MCL, which is on the inner side of the knee, the LCL, it's on the outer side of the knee, the ACL and the PCL are in the center of the knee. The ACL is like the $1 billion ligament there. It's It's got more articles written about it in orthopedic journals than any other structure in the human body. And it's really only about 30 millimeters long and about 10 millimeters wide. It's pretty impressive how crazy we can get about talking about an ACL, but it's probably because we have a way to fix it, so we talk more about it. You know, when you're a hammer, everything's a nail, and the ACL is our golden spike, really. It's pretty rare that a weekend warrior will need to have their ACL reconstructed. A lot of people watch TV, they watch the Packers, they hear, oh, Jordy Nelson tore his ACL, he had to have it reconstructed. I tore my ACL, I have to have it reconstructed. That's not always the case. A lot of people's knees are stable without having any need for an ACL reconstruction. The only reason you need an ACL reconstruction is if your knee is unstable. But with just a general knee sprain, without any torn ligaments, people often have pain, swelling, that'll slowly subside over time. Again, resting, icing, compression, using anti-inflammatories, and occasionally a knee brace or just a compressive wrap of the knee can be enough to really provide the support you need. Physical therapy, and occasionally actually having surgery for your ligaments are common. Meniscus tear, this is probably one of the most common surgeries I do. It's a tear of the cartilage cushion within the knee. The bones have soft cartilage over the end of them, but they need a little bit of cushion as well. So these cushions in the knee sit there like two semicircles that kind of sit underneath the end of the femur. Here you can see how the femur's got these rounded ends to it. Kind of deepens that shell or that cup that spreads out the stresses across the knee. And so they're pretty important. But more importantly, when they're torn, they hurt a lot. People often tear these when they're squatting, twisting, pivoting. They'll say they felt a pop or a searing pain in the back of their knee. Most common is on the back and the inner side of the knee. The medial meniscus is the most common to tear. It's under the most stress. People will say that when they're walking, they feel something catching in their knee, or when they stand up from a seated position, they can't quite get their knee straight unless they wiggle their leg around a little bit, and then it'll pop straight. They'll feel a lot of swelling inside the knee. And occasionally they'll complain of having a Baker's cyst, which sounds scary and is often read on a lot of MRIs, but it's not a bad thing. It's just a result of having a meniscus tear. It's just fluid that's been able to sneak through the tear in the meniscus outside of the knee and just collect in the muscles behind the knee. Once you get rid of the meniscus tear, that Baker's cyst over time generally shrinks in size, but it may always be there. They by themselves aren't a problem. Meniscal tears, resting, icing, compression, that'll help with the pain. If you have mechanical symptoms, that generally will not go away with time. That's why most people come to see me, as they have these mechanical symptoms that recur. Oftentimes this requires an MRI and oftentimes surgery. Meniscus don't have the potential to heal themselves like the tendons we talked about earlier. They don't have a good blood supply. So when they tear, there's no way for blood to come and for the tendon to actually heal itself. Achilles tendon rupture. This is almost always men, somewhere in their 30s to 40s. I think 33 is probably around the golden age for this. Usually it happens with an active plantar flexion. They'll say that they went to take off or change directions and they heard a loud pop and felt a searing pain in the back of their ankle. And a lot of people will say, I thought it was shot. So they'll just hear a really loud pop and they'll just feel a burning in the back of their leg. It's really funny. It's like, you were like in Fond du Lac in your backyard, you didn't get shot, you know, like this wasn't like downtown Chicago or anything. Like, I don't know, that's what I thought it was. This is not common overall, but for a very specific group of people, these men in their 30s to 40s, this is fairly common. The problem with this is that that's your power for pushing off on your foot. So if you have a torn Achilles tendon, you can't go up on your tiptoes on that side, and you have problems walking because you can't push off to propel yourself forward. So people will walk with kind of a stiff-legged pirate gait, you know, peg leg kind of gait. Ice compression, excuse me, NSAIDs, and then it used to be that we always did surgery on these for young, active, healthy people. In recent years, there's been some studies that have come out that show that using a special kind of splinting and beginning functional rehab early, you can actually get this to heal very well non-operatively. And it actually works really, really well. It avoids the complications of surgery, and it still has a great outcome. You know, if an orthopedic surgeon is recommending not doing surgery, it must really work, because we love to operate. Ankle sprains, everybody here has had at least one ankle sprain, whether it's coming down off a step at a baseball game or running in the backyard and stepping in a hole. Usually it's an inversion of the ankle, pain along the outer side of the ankle, bruising, swelling, difficulty walking. Important thing to remember for an ankle sprain is most ankle sprains are fairly benign. They'll go away on their own. Some ankle sprains, quote unquote, are actually fractures, and you may not know it. And I oftentimes will see people who said, yeah, I rolled my ankle like 3 years ago and it just still hurts, and I get an x-ray and they have very clearly broken their ankle 3 years ago, but never came to the doctor. If you sprain your ankle badly and you are not able to put weight on it either immediately after the sprain or even a couple hours afterwards, you should probably come to the ER or the convenient care and at least get an x-ray of your ankle. Not being able to bear weight is an indication that you've either displaced the joint itself or that the ankle mortise itself is unstable. So if everybody when they sprain their ankle limps around, hops around, they don't want to put weight on it, but 3 or 4 hours later, you put some ice on it, you took some Ibuprofen, and you still can't put your weight on it, you should probably have it checked out with at least an x-ray. Low back pain. This is harder to exactly put your finger on what causes it, but it can occur at any age. Some people know when it happened, they were lifting something improperly, they twisted the wrong way and their back hurt. Oftentimes people who have low back injuries have another common problem, which is really poor flexibility, especially in their hamstrings. The tightness in the hamstrings also leads to low back issues. They have poor core strength as well, which is your core muscles actually support your lower back and provide some stability to your lower back. So another reason to work on your core strength, I guess. Some people will have pain just at the level of the waistband in the back. Some people have pain that radiates all the way down their legs. Some people even have pain that goes down to their foot and may have numbness and tingling in their foot. That generally indicates that there's been a rupture of the disc in the back and that there's something pressing on the nerves that go down to the foot. This is very miserable. People hate it. If that's occurring, you're getting pain radiating all the way down the back of your leg and it's numb and tingly, you should definitely see somebody. They may not recommend surgery, but at least you get an MRI and you know what you're looking at and you know what to expect. For people who have low back injuries, I think the only thing that's a little bit different here than the rest of what we've talked about is I recommend that people actually get active rest, which means be up and walking. Sitting down, laying flat, it may make you feel a little bit better, but it's not going to make you get better any faster. I think actually getting up, moving, doing low impact activities will actually increase your blood flow and it can get this disc to heal a little bit faster. Occasionally this actually requires surgery, but if you can avoid a spine surgery, you should. That's the one surgery that I personally don't ever want to have. The hardest part about having a back problem is there's really no way to be comfortable. People don't feel comfortable laying down. They don't feel comfortable sitting down. A lot of people actually feel most comfortable standing. So you'll see a lot of people standing up and kind of like leaning back like this to try to relieve the pressure on that nerve. It becomes very annoying to everyone around them when you're trying to eat dinner and they're standing up like wandering in circles. So if you see somebody doing that at dinner, or the gentleman standing in the corner of the school recital and he's just standing pacing in the corner, you may want to ask him if he's had his back checked out recently. Shoulder injuries are very common. Everybody has heard of rotator cuff injuries, knows somebody who's had a rotator cuff repair. It's pretty rare to actually tear your rotator cuff in a sport like throwing a baseball. It's more common with overuse to have an attritional tear or that tendon just gets so weak that it kind of tears on its own. The other time that it happens is when you fall and you dislocate your shoulder. A shoulder dislocation in a person over about 45 years old almost always has a rotator cuff injury associated with it. People have pain with reaching overhead, reaching out in front of their body, lifting things away from their body. And they also notice that their shoulder gets fatigued easily. Christmas time, people hanging lights outside of their house, they just can't put up any more lights because they can't reach away from their body, even though the lights are very light. NSAIDs are a good start for this, and then physical therapy, you can see, I obviously think that that's very important. I would say 85 to 90% of people will get better from a rotator cuff irritation or strain with non-steroidal anti-inflammatories, good physical therapy, and occasionally a cortisone injection. But if you do a good physical therapy program, you actually listen to the physical therapists and do what they say and do the home exercises, almost everybody can make that go away on their own, which is good. You don't want a shoulder surgery either if you can avoid it. Elbows, both golfer and tennis elbow. Tennis elbow is on the outer side of the elbow. It's from hitting backhands, that's how it got its name. But you don't have to be a tennis player to get tennis elbow. Similar with golfer's elbow, that's the inner side of the elbow. It's from coming down like this with your golf club and maybe grabbing a little bit more ground than you hoped to. And sometimes it's from throwing golf clubs. That's a problem. But it's very annoying. And the problem is that you don't realize how much you use your hands and how important your elbows are to interact with the world until it really hurts every time you move your arm. And then this really becomes a problem for people. Again, rest. Occupational therapy is really valuable in treating this. They can show you some specific exercises. They can set you up with things like counterforce bands, which are like this band that you see here on the arm, which actually kind of compresses the muscle. It takes a little bit of the pressure off the insertion of the muscle onto the bone, which is where the problem is. Occasionally we have to do injections, which are fairly successfll, and very rarely we actually have to do surgery to remove the torn tendon tissue on the elbow. So now getting to the part that's probably most valuable is just how do we prevent this? What can we do to make sure you don't end up sitting in my clinic waiting to see me? I tell people to have a plan. Like if you're going to start working out, or you know that you got a summer coming up where you're going to plan to do some stuff, you're going to have a family reunion, there's going to be playing volleyball and doing all this kind of stuff, and you want to participate in that, and you don't want to be the person that ends the family reunion because you have to go to the hospital. Have a plan. Avoid overdoing it in short bursts. Decide that 3 days of volleyball is not going to be the only 3 days of volleyball I play. I'm going to start now, 1 day, 2 days, work up to 3 days. Realize your limits. That's another really important distinction. None of us are as young as we used to be. And although our brains want to do all these things, our bodies will reject those ideas very quickly. So I would tell people to not look at Michael Phelps and Gabby Douglas and Simone Biles and think like, boy, I could just get to that level. I'd be happy. Go to the gym. Go to the gym and find the person that walks in, and the two people at the front of the gym say, oh, hey, Larry, how you doing? Or Sally, how's it going? And be like, I want to be like that person. I want to be here enough that these people who work at the gym know my name. I don't need to be on TV. I'm never going to be there. But I want to have a routine or a schedule so that I'm spending my time here at the gym rather than thinking about what great things I'm going to do and then trying to go out and do it when I'm not prepared. Also, avoid high impact activities. There's a lot of ways to get good exercise without having to do high impact. This CrossFit's kind of a big craze right now. You probably know somebody who does CrossFit because they only talk about CrossFit. But it's going to make me a lot of money in my career because there are so if people want to do it, that's fine. But it's tough. It's a lot of high impact, quick motions, poor form, and there's a lot of injuries that come from it. So pick something that's lower impact. Biking is great. Swimming is the best. That's the lowest impact. If you fall down while you're swimming, it's pretty cool because you're just floating. So you can't really hurt doing that. And I tell people to cross-train. If you're training for a half marathon with your family, don't just go out and run every day. You got to give your legs a break. You got to give those muscles that work only for running a break. So try riding a bicycle. Try swimming. Remember to lift weights. It's important. You're not going to. Don't worry. No one here is going to get too muscular. I hear that all the time. It's like, well, I don't lift because I don't want to get too muscular. Like, if it was that easy, trust me, we'd look a lot different. It's just not the case. It's just not the case. So do those things because lifting weights and training, even your upper body, for if you're going to be a runner, you're going to run a marathon or something, it's so important to have strong upper body because at 26.2 miles, every part of you hurts. Your shoulders, your arms, you gotta be trained for your entire body. Tell people to start with their diet. You have a lot of new demands starting when you pick up a new workout routine. You need to have the right fuel in your body. The other important thing that people don't realize is it's so much easier to compete in these activities that you want to compete in if you weigh less. If you're not carrying around an extra 20 pounds, it's easier to protect your body and not get hurt. Think about trying to play a game of tennis with a 20-pound backpack on. Well, that's what your body feels if you're 20 pounds overweight. So I tell people, use diet at first. Just get your exercise program started because it'll make it easier. And it's actually more predictable to lose weight with diet than it is with exercise. When you exercise, your body needs more fuel. Your body thinks, hey, this is caveman days and I'm running away from a saber-toothed tiger. Next time I stop, I need to eat more so when that saber-toothed tiger comes back, I can run away again. When you exercise, you're actually taking in more calories whether you know it or not. You'll just slowly start to eat more. And it's because your body needs it. Your body needs it to keep working. But it's very easy to stop exercising. It's very hard to stop overeating. So I tell people start working on your diet first. You'll have much more predictable weight loss to begin with. And then this is just like a shameless plug for vitamin D. Vitamin D is very important. We're still learning all that it does inside the body. It's in every cell in the body. It's involved in most interactions the cells make within the body. It contributes to bone health, which we know about. It contributes to muscle health, which we're learning more about. Here in Wisconsin, because we're so far north on the globe, we just don't get enough sunlight to have enough vitamin D. 2 ways to get vitamin D. One, to eat it through vegetables and fortified foods. The other way to do it is to get sunlight. But unless you're working in a field all day with your shirt off, you're not going to get enough sunlight in Wisconsin. So I actually recommend that all my patients supplement their vitamin D. And this is what I tell them. There's no hard and fast rule on how much you should be supplementing vitamin D. But I usually tell people 1,000 international units of vitamin D3, which is what you can normally buy at the grocery store, and then 1,200 milligrams of calcium, which you sometimes can get a combination pill. I take this, my wife takes this, my mother takes this. I tell everyone to do it because you wouldn't believe how many times someone comes in and they said, oh, I just had a little fall and I broke my wrist. And I checked their vitamin D level and I get like 2 little red stars and a critical low, and I get a phone call from the lab saying, like, this person's vitamin D is 4. And it should be 40 or higher. And so I tell people that if you're going to do one thing, if you leave here today and you do one thing, which is probably forget everything I said, but if you're going to do one thing, do this. Go stop at the grocery store and go to the supplement aisle and just pick up some vitamin D3. You're not going to overdose on vitamin D3. It's not very expensive, and it's very easy to take. They're small pills. This is the most fun part about starting a good workout program. This is my favorite part, is getting the gear. So I usually pick a sport that I want to do. I go out and I buy the best of everything, and then promptly set it in the garage and get it on. And I'm sure everyone here is about the same. That really nice treadmill that's now a coat rack. And like, what do I buy these shoes for? I don't even own a bike. Why do I have biking shoes? You know, get the right shoes. It's important. Cushioning and support are important things that I never thought about before. I used to buy shoes based on color. I'd go into Rogan Shoes and I'd say, where are your blue shoes? And I'd say, well, what are you going to do? Are you going to run? Are you lifting weights? I said, well, I'm wearing blue shoes. Where do I find the blue shoes? And so the more I learned about running, being active, proper shoe wear, the more my feet started to hurt, my back started to hurt. I thought, maybe I'm not wearing the right shoes. I actually went to a Fleet Feet store in Madison. It's a running store. They have some, I don't know if they have one here in Fond du Lac, I know they have one in Appleton. But it's one of these stores where you go in there and the people who work in there are runners. That's what they want to do. That's what they dedicate their life to. And they'll always want to talk to you. And just ask them to look at how you walk. They'll have you take your shoes off and walk barefoot. They may even have a treadmill in there and have you walk on a treadmill, jog on a treadmill. And they'll help you pick the shoe that fits your body, fits the way your foot falls on the ground. And you don't have to do that just if you're going to start running a marathon. I would recommend doing that before you buy new walking shoes or new work shoes, because you might be buying the totally wrong pair of shoes. I see a lot of people that have like these really soft foam or memory foam Skechers, or and there's a couple other brands that make this like minimalist running shoe also. People think like, wow, it looks cool. I see the super fit people wearing these. I should wear these. You probably shouldn't. You gotta kind of figure out what works for your foot. Because if you don't wear the right shoes, that's your connection to the ground. That hurts everything from the bottom up. And so that would be another thing I'd say it's important to do. If you're going to buy new shoes, get the right fit and talk to somebody who knows what they're doing. Sometimes you even need to have inserts in your shoes. It kind of stinks to like, oh, I got to put these in my shoes every time. Well, if it makes you feel better all day long, it prevents you from getting hurt, it's worth it. It's worth the time. There's a lot of technology out there to use, different running apps you can get on your phone. There's all kinds of beginner classes at the YMCA, here at Zone. You can find all kinds of classes and people who are just like you looking to start the same program. It's very helpful to have other people's input. If you start a running program, I tell people, consider this like Couch to 5K program. It's basically for people who've never run a day in their life and they want to start. It gives you a plan on how to start that. I say tell people to start nice and slow. If you think you should run a mile, do a half mile. If you think you should run 3 days a week, maybe do 1 day a week, 2 days a week to start. Start half as intense as you think you should, because there's going to be some soreness, there's going to be some small injuries when you start, and if you're trying to push yourself too much, you'll get injured to a point where you just have to quit completely, and then it's very hard to get restarted again because you think, geez, last time I started I couldn't walk for 3 weeks, and now I'm going to get started again. What do I do? If you get started and you make it through that first initial 2-3 weeks and you're kind of starting to get a little bit of a habit going, and you feel like, oh, this is easy for me, I can do this, is no problem, slowly start to increase what you're doing. Don't go from 1 mile a week to 6 miles a week. That's too much. Take it nice and slow. And these programs like this Couch to 5K, they give you a daily plan so you know this is all I have to do. And even if you feel so good that you're like, I could even do a little bit more, don't. That's always the first step to failure, is thinking, you know what, I'm good enough that I can get off this plan. Slow down if needed. If the plan is going too fast for you and you don't feel like you're ready to go to the next step, slow down. If you have a race that you sign up for a 5K or something, run, walk, and it's coming up in 3 weeks and you're behind schedule, don't race to it. Don't try to get to it quicker. Take your time getting there, and if you need to slow down, slow down. There'll always be another charity 5K in town, always. Important to remember to take care of your body right before and right after you partake in any physical activity. So remember to hydrate during the day if you're planning to go for a run that night, or you got a softball game that night. Hydrate during the day because you won't remember to during the event. Warm up, cool down, both very important. People say, well, I only have 30 minutes to work out. And I say, that means you have 15 minutes to work out, because you should spend at least 10 to 15 minutes combined between your warm-up and your cool-down. So if you only have 30 minutes to work out, don't just go outside and run for 30 minutes and then run back inside and be done. You gotta warm up a little bit. You have to cool down. It's important to stretch, especially after you're finished with your activity, so that you're ready for your next activity the next week or the next weekend. A little bit about treatment. This is that Rice phenomena that we kind of discussed earlier. You'll see this written everywhere. You'll get it as advice from doctors in all different fields. But resting is important. The one caveat is the back injuries. I think getting up and moving around is actually a little bit better for you. But if you have an injury, unless you're an elite athlete or you're competing, I wouldn't recommend pushing through it. I mean, if you're doing exercise for physical fitness or just for fun, you don't gain a whole lot by pushing through it necessarily. Give your body some time to rest. While you're resting, work on range of motion. Don't let the joints get stiff. Work on your flexibility, but don't be pounding on your joints and your muscles. Icing, like I said before, unless you give yourself frostbite, there's really no way to hurt yourself with icing. Okay, so I tell people, go to the grocery store, buy 2 packs of frozen peas, and then alternate them in and out of the fridge. They're moldable, they stay cold, and they do a really nice job for cheap. 20 minutes on, 20 minutes off. Put something between your skin and the ice source. So if you're wearing sweatpants, leave your sweatpants on. If you're wearing socks, leave your socks on. The ice will get down there. It'll cool the joint down like it's supposed to. Compression, also important. But compression should be light compression, very light compression. There was always a saying in my residency, there's nothing as dangerous in the world as an intern with an ACE wrap, because you can really hurt yourself by putting things too tight. You can make a tourniquet if you wrap things too tightly. So I tell people, buy an ACE wrap, lightly wrap it on, and it's supposed to prevent the knee or the ankle or wherever you're putting it from swelling more. It's not supposed to crush the swelling out of the joint. Another thing is these compressive sleeves, like sometimes you'll see them like seen on TV, like the Brett Favre copper fit. I don't know if I believe in the copper part of it, but it is a good compressive device and it stays up, and so that's a good thing to wear if you're noticing your joints are swelling. Try a little bit of compression. And then elevation. This is probably the most represented and misunderstood thing that we talk about in orthopedics is the importance of elevation. People think if they're sitting in their recliner with the feet up that their leg is elevated. That's not an elevated leg. It's still below the level of your heart. You have to think of your heart as being at sea level. Anything below your heart is below where it needs to be for elevation. So what I do if I injure myself, or sometimes if I just like do a lot of surgery and I stand all day and I feel like my legs have retained water and my feet are swollen, I lay on the floor with my butt all the way up against the wall and I put my feet straight up on the wall. And it works very well. 20 minutes of that, you stand up, and you feel like a new man, you feel great. If you have an injury, the higher you get the foot or the higher you get the wrist, the faster the swelling will go away, the faster the pain will go away. So this is a little picture of a guy laying down with his leg up elevated on pillows. This is at least 3 pillows, and I would recommend if you're going to lay flat, put at least 3 pillows, support behind the knee so it's not hanging free, and put something soft into there. Don't stack it on top of like a bunch of books, because that will compress the neurovascular structures in the back of the leg. So nice soft pillows up and high, elevated. For hands, wrists, what I tell people to do is make sure your fingertips are above your wrist is above your elbow, and your elbow is at least at the level of your heart. That way things will follow gravity and run down. NSAIDs, things like ibuprofen and Aleve are traditional NSAIDs. Acetaminophen is not a true NSAID. It's more of a antipyretic or a analgesic, but they all work well. And I usually tell people, if they're going to do ibuprofen and Aleve, to kind of stagger when they're going to do the medications. So if you're going to plan to take like ibuprofen 3 times a day and Tylenol 3 times a day, don't take them at the same 3 times. Like take your ibuprofen at 8 a.m., Tylenol at 10 a.m., Advil at noon, Tylenol at 2, and stagger it a little bit. You can use ibuprofen with Tylenol. You can use naproxen or Aleve with Tylenol, but I wouldn't use ibuprofen with naproxen. That's 2 NSAIDs. That's too much. The best thing to do, check with your primary care doctor or call our office and say, yeah, this hurts and I'm going to be starting this NSAID. What do you recommend I take? The back of the bottle usually has a pretty good schedule on it, but I think if you get confused or you're worried you're going to hurt your kidneys or hurt your GI system, give us a call. Because if you take too much of these, you can get little ulcers in your stomach. If you take a lot of them, you get problems with your kidneys. Physical therapy is our most valuable resource in the orthopedic world. They are awesome. They know so much about exercise, flexibility, movement. They've seen the injuries as often as I have, or more often, because that's what they spend their whole day doing is making people start moving who don't want to move, and making them work on improving their range of motion. And so they have all the tricks and all the tools, and we have a great physical therapy setup out there at Health Plaza A. Setup here is awesome as well. It's really nice. So I tell people who come to see me from out in the community or whether they get referred from the primary care physician is, if you see me, you're probably going to at least get some consideration for physical therapy. Now, whether it be actual physical therapy or maybe some exercises I give you to do at home, I think that's really valuable, not only to heal your current injury, but also gives you the knowledge to prevent injuries in the future. They have a lot of different methods, like I said, massage, mobilization of tendons and muscles. They use these what we call other modalities, which are ultrasound, iontophoresis, where they kind of force steroid into your skin with electrical pulses, basically. These TENS units you've probably heard of. So I think physical therapy is extremely valuable. Just kind of start to wrap up the talk. This is more about when can you start to consider you see an orthopedic surgeon? When can you say, yeah, maybe I just can't take care of this on my own. This is not working. Something's really wrong. I think I need to see somebody for it. With the shoulder, usually I worry a little bit when people say they have pain that continues at night, or they get woken up at night because of the pain in their shoulder. Sometimes they'll even say it's down the arm more so than at the shoulder. Oftentimes that's an indication of a more serious rotator cuff injury, rotator cuff tear or partial tear. And then an even bigger worry is when people don't have the ability to raise their arm. And sometimes it's not even painful. They'll just say, I just can't get my arm up there. They'll lean back to try to pick stuff up, but they really can't lift their arm up. That's often a sign of a rotator cuff tear, and that's something definitely worth seeing an orthopedic surgeon. Rotator cuff tears are a little bit of a ticking time bomb. If you let it go too long, 6 months, 8 months, you may find that you're not able to have that repaired. The muscle retracts too much, the tissue becomes too weak, and you just can't repair the rotator cuff. And then you're kind of down a nasty path you don't want to go down at that point. So if you get to that point where you're having a lot of pain at night, or you can't lift your arm, it's time to come see somebody. Elbows, oftentimes our primary care physicians see a lot of issues with tennis elbow, golfer's elbow, work in wellness sees a lot of this. Oftentimes they'll try steroid injections, physical therapy. If those things fail, that's when you see an orthopedic surgeon. Low back pain, again, if you have pain and numbness going all the way down to your lower back, through your buttock, down the back of your leg, and to the side of your foot, it's time to see a doctor. Or if you have weakness in your leg, if you feel like that leg just doesn't have the power that it used to. Hip pain, again, if you feel any catching in the hip or giving way or difficulty standing on the hip or pain when just standing still, maybe an indication that you actually have arthritis of the hip more so than just a muscle tear or muscle strain. In the knee, meniscal tears are the most common problem, catching or locking in the knee or even giving way. Sometimes people will say, yeah, I went to step down and my knee kind of gave way. That's time to see an orthopedic surgeon. Again, ankle, inability to bear weight immediately after the injury or 3 or 4 hours afterwards. That's it for me. If you guys have any questions, feel free to fire away. I'll answer as many as I can. Go ahead.
Do you have dry needling therapy listed? I didn't see it listed, but
That's a good question. I don't know if any of our therapists do dry needling.
They do.
Dr. Royce.
Oh, you do? Okay.
It's a brand new service that we're going to be
cool.
offering starting now. We have it in Ripon, Waupun, and Fond du Lac. We have a couple therapists that do dry needling, but you do need a referral for it.
okay, I have had it done, and it seems to have really helped.
Yeah. I've heard a lot of patients tell me that they had success with that. So I don't do it. I don't necessarily know how to do it, but if it's helping, it's worth trying.
Sometimes when you buy like a bigger jar or whatever of Advil or Aleve, and then you use it, and then everything's good, and then you forget about it and don't need it, and then the next time you look at the bottle, it says expired like January 2016, and now we're in August.
Yeah.
How long of a range does that drug still have an effect on if you use it or not, or should you just throw it away and get a new bottle?
So that's a good question. I think the legal doctor answer is you should throw it away and get a new bottle. But it's not like it doesn't turn from ibuprofen into cyanide on January 1st. It's what really happens is they can no longer, after that expiration date, guarantee its efficacy. So if it used to take your pain from a 10 to a 6, maybe when it's expired, it takes it from a 10 to an 8. So every drug's a little bit different. Their stability is a little bit different. That's why they have different ranges of expiration dates. I would say if you're concerned about it, buy a new bottle, definitely. Half of taking anti-inflammatories is your perception that it will work. So some people take anti-inflammatories and they say, I know this isn't going to work, and guess what? It doesn't work. People who other people take it said, well, all I need to do is take 2 ibuprofen, my doctor said, and I'll feel great. They take 2 ibuprofen, they feel great. I don't know, maybe they took 2 pills, but half of it's placebo effect, and so if you believe when you open the bottle, like, oh, this is expired, it probably won't work. I guarantee it won't work. Any questions? Go ahead.
What's your opinion about stretching before and after dynamic versus static stretching?
That's a good question. I think there's been a push probably like since the 90s that dynamic stretching is maybe better for athletes, especially elite athletes. It does take a little bit more focus and probably some actual training on how to do it properly. I generally just tell my patients to try to get any stretching in. But I think, yeah, if you're going to plan to do real vigorous activity, and you go from being more from a weekend warrior to being a true athlete who's working out 4 or 5 days a week, competing monthly, and I think dynamic stretching is a good modality, but I think you need to educate yourself on how to do it properly. But for the average person, any stretching is good stretching because most people do none. Katie, do you have something? Oh, so Katie's going to be collecting these little slips here, I think. Yeah, do you have a question again? Yeah, go ahead.
Is there such a thing as a frozen hip?
A frozen hip. I've never heard of a frozen hip. That doesn't mean it doesn't exist. We see people with frozen shoulder frequently. It's usually women, oftentimes diabetic women, who have excruciating pain in their shoulder. They can hardly reach. They always say, the first thing they say is, I can't put my bra on. They can't get my arm behind my back because their arm is so stiff. It's very miserable. It lasts usually between 18 and 24 months to go away. Shots can help, but it's a very slow process. That's the one disease that you see people making Facebook groups about and support groups online because they're just miserable. So you don't want to have frozen shoulder. If you get close to thinking you have it, you should see somebody right away. I've not heard of somebody having frozen hip. More commonly, what people have with hip problems is severe hip arthritis. And they get to a point where they can't actually, if they flex their hip up to 90 degrees, they actually can't rotate it at all. It's because there's so many bone spurs and the joint is so tight, there's no rotation left.
All right, I'm going to have you pick a winner.
Drawing door prizes. I didn't even get to put my slip in. All right. Can't read, so.
Maria Metke, who I think left, so I'll get it to her. I'll get it to her.
You don't think we should?
I'll get it. Oh, she's right there. All right, thank you everybody so much. Have a great rest of your day.